but I'm real happy to be with you all. I come from the Center for Behavioral Health Statistics and Quality at SAMHSA. If you're not already familiar with our group, we're a relatively new unit. We've been around for about 4 to 5 years, and we are a federal statistical unit. We have a group of behavioral health services researchers and also evaluators. In my division, on the other side of the house, we have statisticians that are largely involved in data collection for some of the surveys that you all are probably already familiar with, like NIMS, NSATs, NSDA, things like that. We don't get involved in as much in the program and contract-related side of the business that is part of CSAT, CSAP, and CMHS, the other centers at SAMHSA. So this is our standard federal disclaimer, just to say that the views that I'm going to present today are not necessarily the views of HHS or SAMHSA. They are mine. And today, what I'm going to do is give you all a brief review of available research on various integration models. There's lots of different ways to think about integration, as I'm sure you all well know. In some cases, we try to integrate behavioral health in primary care settings, and that's going to be the main focus of what I have to say today. But there's also the reverse of that. There's trying to integrate primary care in specialty behavioral health settings. And there's a lot of steps on the way in between, and I'm going to unpack that during the course of what I have to say today. I'm going to focus on children as an example because it's a nice way to narrow the topic, and also because I'm a child mental health services researcher by training. In case you're suffering from the post-lunch lull, I'll give you a brief synopsis of what I've got to say. So what I want to say to you all, and you know, I think I'm going to be following up on a lot of themes that you've been hearing today from folks that have spoken so well before me. And that is this, that social work was there from the beginning when some of these primary care-based, team-based models got set up, that I believe, as everybody else has been saying, that there's a real opportunity for a leadership role for us should we choose to step up to the plate and to take it. There's going to be there are training opportunities and other research-related resources. I think they have a potential to be influential, and I think it's just a real opportunity for our field right now. So the second stage of what I'm going to talk about in terms of fleshing all that out is just sort of reflect some on how practitioners and other stakeholders can best advance integrated healthcare delivery. I should also say that I plan the talk to not take up the full time so y'all could ask questions. So children's mental health issues, as I'm sure y'all know, are common. Estimates of the prevalence of mental health disorders in kids suggest that anywhere between 13 to 20% of children in the US have a diagnosable disorder. Some of the most common ones, as you know, ADHD, depression, anxiety, and you can see the lifetime prevalence among adolescents there, respectively, in order. Good news is that growing numbers of kids are receiving outpatient behavioral health treatment. Olson and colleagues at Columbia did a study that suggested that there was an increase from 9.2% in the late 90s to about 13.3% more recently in the numbers of children and youth that are receiving outpatient behavioral health treatment. Children's behavioral health conditions are now the largest area of aggregate medical spending, about $9 billion of all health disorders that contribute to child health expenses. So this is a big issue, and you can see that average expenditures per child are about $1,931 per kid. So primary care providers are playing an increasingly larger role in the provision of outpatient mental health care. Indeed, pediatricians find that anywhere between 15 to 25% of the kids in their practices have significant psychosocial issues that make them now the most common condition in pediatric primary care. Some of the common barriers, we've already been talking about them today, and this is to integrating behavioral health in primary care. Physician reimbursement is an issue. Time, because I think it was Robin that had a slide that sort of illustrated the differences between acute care and primary care settings. There's a different sort of way in which the practice functions. There's challenges with accessing specialty mental health care. There's a behavioral health workforce shortage, which you all, I'm sure, are very familiar with. Another issue is that although primary care physician groups have made some attempts to improve their mental health training, some PCPs still receive very little mental health training. While many pediatricians agree that ADHD is part of their scope, they believe that they should refer children with other behavioral health conditions to specialists. So what happens when you get a kid with anxiety? What happens when you get a kid that has depression? I think Robin also alluded to this earlier, that some physicians, for example, may be unfamiliar with social workers' scope of practice in mental health. I did a study a couple years ago that suggested that very thing. Indeed, I had a pediatrician tell me during course of qualitative interviews that they sometimes thought they were unfamiliar with what an LCSW meant, and they thought that social workers were there just to provide the bus passes. So we have a public perception issue, and I think other folks have said that here before me. Another big challenge is that, as you all know, there's stigma in addressing mental health issues. Indeed, I was really surprised. I don't know if you all saw this article. It was in the Washington Post just this past week, but it talked about a study that was done with a couple of thousands of physicians. And what they found, that about half of them indicated during the course of the study that they met criteria for a mental health condition, but they had decided not to seek treatment. And some of the reasons that they indicated for that are some that are well known to us. Part of it was that they were worried about stigma and the inability to find time to do it. They're busy professionals themselves. But the thing that really caught me was the effect that that might have on their maintaining their licensure. So that really stuck out to me. So what are some potential solutions to this? One potential solution, and other folks ahead of me have alluded to this, is the collaborative care model. The collaborative care model is not a new idea. Some folks that I work with are fond of saying old ideas wearing new clothing. And so really, the idea of producing team-based care has gone back more than 5 decades. The American Academy of Pediatrics, for example, came up with the medical home idea back in the late 60s. And so it's this idea of doing team-based care has been around for a long time. We all know that there are issues with, shall we say, competing cultures of care. When you put together behavioral health physicians myself and encountered these same sorts of things. But I think even though those things are there and we're all aware of them, I think we really owe it to our clients, we owe it to our colleagues, and for the purpose of improving health outcomes for the sake of the health system. There's a lot of benefits, I believe, that collaborative care models offer to improve access to care. We talked about that just a little ways ago. One of the things is that if there's a behavioral health provider on site, this person can deliver the service right there on the spot and then facilitate connection to specialty behavioral health in other places. In addition to that, I think there's this culture of providing when both of these types of providers are together in the same team, when they learn to function more closely together, I think everybody really learns from each other, and this also enhances the overall provision of care. So, as I promised, social work practice roles in primary care settings began to be developed about the same time as team-based care. You can see the work of Hookey there, but way back in 1976. The research on collaborative care models so far has mostly focused on acute care settings. There's some reasons for that. You can see Abramson, Mizrahi, and Bergman and Fritz, and also Kitchen and Brook have done work on this. However, even though there's a lot of work that's been done about acute care settings, there are some primary care-based collaboration models that have developed. Coleman and colleagues, back in 1976, did a study on the inclusion of a psychiatric social worker as a member of a pediatric team in a prepaid group practice way back in the 70s. More recently, Crichton and colleagues in Ontario, Canada, described a social work program in a hospital-based family practice unit. So in the acute care setting overall, but a clinic within that setting. And Monty and Rosner just last year described a medical home for medically complex patients within a hospital system. So we've been doing this work. Earlier, I believe it was Colleen that laid out a framework for thinking about collaborative care. This one happens to be SAMHSA's particular model, and I noticed, even though I just saw the other one flash on the screen, there's a lot in common with this. But basically what you see are differing levels of collaboration, moving from minimal collaboration on the far left-hand side all the way up to full collaboration in a transformed and merged practice. In between, there are a number of stops along the way. The key one for us to be aware of, I think, is the third one, where there's basic collaboration on site. And then with each successive step, what we're starting to see is increase in integration of systems. For example, are we sharing medical records, perhaps an electric record? Another example of this is, are we starting to see buy-in from senior leaders within the healthcare setting that are kind of like champions that help sort of facilitate the development of the collaborative care model. I think, Tom, you talked about this related to ACOs as well. There is also, behind all this, there are 5 key differentiators about these that are related to these different levels. And they include degree of co-location. So are you just a side-by-side practice? Do you have your office as the behavioral health clinician right next door to the primary care practice? Or are you functioning more as part of an integrated team? What does the clinical delivery look like? For example, are you sharing screening? Is there shared treatment planning? What is the experience from the patient's point of view? Is the patient feeling like it's still fragmented yet, or are we getting the sense that things are much more tightly functioning together? At the practice organizational level, that is more about like having a champion to sort of oversee and facilitate the process. And then lastly, what does the business model look like? So how are you getting reimbursed? Some folks have talked about that, and we know that it's a patchwork, and I'm going to unpack that a little bit more shortly. Beyond, yes, Gene.
These references for this collaborative care model, is that behavioral health and primary care only, or are some of the collaborative care models referred to social services?
I think this was largely focused on behavioral health broadly, but I think there's some overlap there. Nevertheless. So in addition to all this, there's some interesting twists on collaborative care that I want to just put out there for everybody to think about. So is it just basic referral? Is it consultation where there's not much involvement with the patient directly? What is the degree of co-location, like we talked about before? Are we talking side-by-side practices? Are we talking more integration together in a team? Health IT offers some really, really interesting kind of ways to think about collaborative care. Could you not be in the same physical location, but could you pipe somebody in through video conferencing? How can you use telemedicine to support practices that are, let's say, in rural areas or places where there's not enough volume in the particular practice to warrant co-locating someone, but there's enough there that you need to have somebody available every so often. Mobile behavioral health teams. Read an interesting study a ways back about a group of folks in a rural area who got together their integrated primary care behavioral health team. And they went around and rode a circuit in a rural area and had clinic for a day in different sites. The reverse of that, what about a fixed location team where you have a good example of this is the Massachusetts Child Psychiatry Access Project. So the state of Massachusetts gets divided up into quadrants. Each quadrant has a behavioral health team with some FTE of a psychiatrist, a social worker, a pediatric nurse practitioner with prescribing ability, and sometimes a psychologist and the social worker are interchangeable. It just depends on the area. But they support all the pediatric practices within the region. So lots of different interesting ways that you can go with this. So I wanted to give you just an example of one pediatric collaborative care model, just so you can get a sense for how it functions, some distinguishing features between specialty care and the collaborative care, and then also I'm going to tie it up with what was the social worker's role. So in this one, done by Campo and colleagues at Ohio State, there was case identification, led to triage. Anybody with safety concerns got an assessment in the ED, and then the child was assigned either to routine care, collaborative care, or specialty care. So the next question is, what are some of the distinguishing factors between those different levels? And you can see them there, starting with the level of impairment. So if we go down sort of the routine column, what we see is that this is largely handled by the PCP and an advanced practice nurse. They're handling cases with mild to moderate impairment. Their complexity tends to be straightforward. Some of the problems that they tend to see are ADHD, emotional and adjustment disorders, and their treatment needs tend to be just medication, self-management, and so forth. Now let's take it up a notch to the collaborative care. So now we're in the moderate to severe range, but there's diagnosis uncertainty. There has been a failure to provide the treatment's not working from level 1. And they tend to see routine diagnoses plus Asperger's on the autism spectrum disorder. And in this case, they also had them treating mild eating disorders. But the treatment needs included psychotherapy and some type of specialty meds. And here's where you see the social worker. In the specialty level of care, it is also moderate to severe, but here we're getting into increasing levels of complexity with legal issues, for example. There's been a prior psychiatric hospitalization. They're dealing with problems that are more severe diagnoses like bipolar disorder, psychosis, things like that. And a higher level of psychotherapy is needed. It's more intensive. There needs to be more intensive work with the family and in-home services, and then this tends to get referred off-site. So I hope that gives you a sense for the different levels and just one way that one group has thought about collaborative care. So what does a social worker do? So the social worker provides patient-family ed, intake assessments. The social worker is responsible for specialty psychotherapeutic interventions, so individual and family therapy. In this model, the social worker was responsible for selected case management and was involved as a school liaison. Very important because I'm sure you all know when a pediatrician asks for the Conners to be done in order to assess for ADHD, it takes the teacher's assessment as well, and the research suggests that getting that back tends to be more challenging for the pediatrician to get. So you'll get a parental assessment of the child's level of symptoms, but you don't get the teacher's assessment. So that's an important thing to address. So 10 years ago, when I headed down this path, there weren't a heck of a lot of pediatric collaborative care models out there, but there's been signs that the research has been growing, and that's good news if you're interested in this topic. There's a lot more CCMs that serve kids than there were in the past. A recent meta-analysis done by Asarno and colleagues at UCLA indicated that so they looked at the effectiveness of integrated pediatric and physical and mental health care compared with usual care. And what they found was that the probability was about 66% that a youth that was randomly selected would have better outcome after receiving integrated care compared with somebody that just got usual care. And most importantly, the strongest effects were seen for the treatment interventions that included collaborative care models. We have all been talking about costs off and on, And I think intention has been turning to that with respect to pediatric collaborative care. Indeed, some evaluations have found connections between collaborative care models and cost savings. Unfortunately, these are mostly done with adults, but I think the good news is that that we should be hopeful that were similar projects done on kids, that we might see similar things, but opportunity for future research if you're interested in that area. Indeed, one study found that for every dollar spent on collaborative care, $6.50 was saved in healthcare costs. So that's good news. We've talked some about reimbursement before, and boy, it's tricky. It's really tricky. Financing is always seen as one of the primary obstacles to doing integrated primary care with behavioral health. It's often seen as a patchwork, but there have been some recent changes that suggest some optimism for us. So hot off the press, I think some folks have alluded to this too, was that 4 new codes were created in the 2017 Medicare physician fee schedule that allow payment to primary care providers for providing behavioral health integration services. So physicians, as we've all seen on an earlier slide, one of their big issues was that they couldn't get reimbursed. And the reason that this is important for the field of social work, even though this doesn't completely help us out, is that I think it kind of turns on the tap in a way, and it's going to create some demand possibly for people in our field, psychologists as well. The reason that I say this is the sort of sub-bullet there that says that 3 of the codes describe services that were furnished using the psychiatric collaborative care model. And this particular collaborative care model provides 2 types of services. It's care management support for consumers that receive behavioral health treatment, and also regular psychiatric consultation with the primary care team. So in this case, the care manager is required to have formal training in a handful of disciplines. One of them is social work. So that's good. I think it's going to cause some physicians to turn to our field. And I'll get into a little bit about more what that might be likely shortly. The second is the psychiatric consultant. And this person has to be a medical professional with psychiatric training and qualified to prescribe a full range of medications. So this could be a psychiatrist, but it also could be a psychiatric nurse practitioner, a physician assistant, and so on. So I think this is some good news because perhaps eventually Medicaid may follow suit, and also perhaps commercial insurance may follow suit. As you all are aware, there's a lot greater variation in Medicaid benefits and coding and payment requirements across states. Fortunately, though, I would direct you to the link there because SAMHSA and HRSA, they fund a Center for Integrated Health Solutions. This link, there are some worksheets that are called the Financing of Behavioral Health Services, State-Based Billing and Financial Worksheets. And so basically what it is for every state in the union, there's a worksheet that explains how, depending on by state, if you're a social worker, a psychologist, or whatever stripe of mental health clinician, when you provide behavioral health services in a healthcare setting, how you might be able to bill. So this is not a panacea, it's not all done, but I think optimism is of the order. It suggests changes are coming. So that leads me to talk about and reflect with you all together on how can we as practitioners and other types of social work stakeholders best advance integration. So we often talk about elephants in the room, and I'm sure you all know that just by sake of numbers, social workers are we are the largest group of mental health providers in the country. And the reason I point this out is because, you know, the greatest likelihood is that when a pediatrician or any other type of primary care provider goes looking for a behavioral health clinician, regardless of the stripe, the chances are greater that they'll run across a social worker than others just by dint of numbers, nothing else. NASW Center for Workforce Studies did a project a ways back on what social workers in healthcare settings do. And so you can see that master's level social workers largely practice, about 56% of them, in fact, they practice in hospital settings, about 11% in health clinic settings. What we don't see so much of is primary care doctor offices, for example. We don't see so much of that right now. There's some good reasons. There's some good reasons for that. What I want to offer to you all is, after thinking about collaborative care models, are how can we work with this from the fact that on one hand, how can we prepare future social workers to practice in primary care settings? On the other hand, how can we build on the strength that we already have freestanding hospital social work departments, and how can we perhaps create fixed location regional behavioral health teams, because hospitals already sort of serve a catchment area of primary care practices. Is there some way that social workers in a hospital social work department could be the behavioral health team that supports some primary care practices in the field? Is there some way that we could do that? I don't know. You all know better than me, but just an idea. So my colleagues and I, we did a systematic review of the effect of healthcare reform on the field of social work. We just recently we published it. I'm fortunate that at CBISC I work with folks like Katie Greeno, whom some of you all may know, Judy Tyke, and also Pete Delaney, and we all collaborated to put this together. And this is sort of the summary, and I'm going to unpack each one of them, but these are some potential strategies based on a systematic review of the literature that's currently out there. So some of the needed skills that you all, indeed, some of you here in this room, in fact, wrote about, would be the ability to work with families and communities, the ability to deliver brief mental health services, the ability to design and short and long-term care plans. And while you all already well know that these are part of the social work curriculum, often they're taught for use in acute care settings. So the question becomes, is it possible to adapt some of these skills for implementation in primary care settings where, you know, if you're a patient, you're typically out in 15 minutes or less? Some folks ahead of me have already said this, and I'll just underscore by saying, what can we do about developing integrated care field placements? Concurrent field theory, practice, coursework, it's our signature pedagogical approach. That's how we train new MSWs. Can we consider expanding the diversity practice placements to include places like integrated healthcare settings, medical homes, ACOs? I think all of these have a lot of potential for us toward the preparation of effective social workers in the future. My colleagues in other federal agencies, and also SAMHSA included here, have identified several integrated practice competencies. You can see the long laundry list of them there. I'll just highlight a few for you. Interpersonal communication is important, collaboration and teamwork, screening and assessment, care coordination. Several people have talked about that already. Cultural competency. Not everybody thinks about mental health in a medical model. Systems-oriented practice we're ready for, and HIT is another thing that is on the horizon. So some social work colleagues suggested that further review of these practice competencies may be needed for social workers in healthcare settings. Next, we turn to clinical practice skills for integrated care. Some colleagues that did a study of social workers who practice in integrated healthcare settings noted that some important skills were learned on the job rather than in the classroom. Some of them can be interdisciplinary collaboration, psychoeducation, cultural competency. I think that learning these during graduate training rather than learning them while you're OJT means that we'll turn out people that are ready to go, they're ready to hit the ground right when they start practice. Two of our colleagues indicated that educators should ensure that health policy that's taught to MSW students should be updated to reflect the current practice environment in healthcare settings. And so some of the topics that might fit within a policy-related course might be healthcare access and disparities. We've talked about some of these themes already. Quality of care, again, another subject that folks have already brought up. And also, just right before I stood up, we talked some about prevention and its importance relative to our field. I've been alluding to this off and on throughout the talk, but knowledge of HIT, I'm sure you all know, is really important because it has the ability to enhance communication between providers as well as between providers and patients. I think one of the key goals here is improving the coordination of care and the reduction of medical errors. I think a particular area of opportunity is the use of the electronic health record for coordinating clinical care. Some other areas that we all may want to think about are, there's increasing therapy that's being delivered electronically, telehealth, and also mobile health applications. So are we training people that are ready to go out into the field and practice using these different new types of health information technology tools? Finally, I want to talk a little bit about research opportunities and think together with you some about where does the research need to go from here. I've heard other people already allude to this before, and I think you all know that building our empirical knowledge research base and disseminating these findings, not just in social work journals, but also other journals, goes a long way to helping the public to understand what it is that we do and why we have the appropriate expertise to lead health reform efforts. And so in thinking about that, where are some places that social work research might go from here? And I think I'm going to echo themes that folks ahead of me have already said. Examining models of care coordination. There's different types of care coordination, different clinical populations. How might that differ? A second would be, what are the activities of the social worker in integrated care, and particularly how those have a connection to health outcomes and cost effectiveness. Another one is, what should the integrated team structure be? Who should be involved there? What's the optimal team membership? And also, how might that team membership vary by clinical population? Collaboration can easily differ by different settings, and so it's important that we think of that. And for those of you that are intervention researchers, thinking about how we can adapt interventions to fit the very brief time period that you get with a patient when you're in a primary care setting. So, what are some of the resources available to all of us out there that do research in this field, that practice in that field, or just interested in dipping the toe in the field? So, SAMHSA has a healthcare and health systems integration initiative, and this initiative aims to improve care coordination across different types of service settings, so primary care, health, schools as well. Indeed, I think this initiative came up because it was in recognition of the fact that behavioral health issues frequently come up in primary care settings. At SAMHSA, we also have the PBHCI, so Primary Care Behavioral Health Integration Program. So this program focuses on providing coordinated integrated services by co-locating primary care services in specialty care settings. So this is sort of the reverse of what largely I've been talking about today. And so we're talking about these types of primary care services available in community-based behavioral health settings. And this largely focuses on adults with SMI. Some of you may already be familiar with SBIRT, so screening, brief intervention, and referral to treatment. And so it's a comprehensive integrated public health approach to the delivery of intervention and treatment services for people with substance use disorders, as well as those at risk. This gets delivered in primary care centers, in EDs, in trauma centers, and other community-based centers where these type of folks show up. Finally, SAMHSA and HRSA both collaborate on this one program called the Behavioral Health Workforce Education and Training Program. It's a collaborative grant program that is designed to increase the behavioral health workforce, and it focuses on social workers and also, in addition, psychologists, professional counselors, psychology doctoral interns, and so forth. So there's a lot of different resources out there that are able to help support the development of the workforce. So in terms of wrapping things up with what I have to say today, I think, even though that there are a lot of challenges to doing this kind of work, I think one thing that I want to leave you all with is that we owe it to our clients and to our colleagues to take advantage of this opportunity at this point in time. Primary care practices are in a process of adaptation to meeting patients' behavioral health needs. I think our field is in a really good position to address this. We were there from the beginning when we started to deliver or started to think about different types of team-based care. I think there's a leadership role for us if we are ready to tackle it. And there are some potentially influential research and training opportunities on the horizon for us. And I think the big goal is this has an impact on when we think about kids in particular, that there's a lot of opportunities for early identification and preventing symptoms from worsening over the lifespan, so everybody can grow up to be fully functioning adults. So with there, I'll pause, and I'd love to hear your questions or comments. Thank you.
Thanks so much. That was a great presentation. And what it really made me think about, because you really focused, this was really our first presentation today that focused on behavioral health. And you make a really great case for two things. One, the behavioral health specialty skills of social workers should be very sought after in integrated primary health care models. And I think that that's very much true. And of course, so much of practice of social work driven by licensure has moved to fulfilling that role as primary behavioral health care providers. And so social workers are ready to do that. It strikes me that from our earlier discussion, what we're struggling with as a profession and for education for the profession are those non-behavioral health roles that are so often important in other coordinated care for different populations, acute care populations or older people with chronic health conditions and so on. And I just note that that's a particular challenge where at this point in time, I think our profession is comfortable in those behavioral health roles, struggling with how do we demonstrate our professional competence in a way that makes it, cost beneficial in some of those other roles. So, just a comment, because this felt to me very comfortable for what I see a lot of social work new graduates aiming to do, whereas the others are more include some more challenging roles that we may not be preparing them so well for.
Sure, yeah, I can see a couple of reactions. One is that just in terms of the role itself, I can see primary care practices out there that see, a wide range of needs. So we have the psychosocial needs as well as the behavioral health needs. And so, is it possible for a social worker to walk in and demonstrate the facility with behavioral health, but not just that as well, taking on some of we have a long history with case management, and there's some real opportunity there. Then the flip side of that has to do with the research. So I'm fortunate because at SAMHSA I work on a health economics and finance team, although I'm a social worker in background, and I have a health economist. And it's really, it makes me think that for everybody else out there, make friends with health economists. They're really valuable. I know folks from BU talked about having that expertise there, but I think that kind of collaboration would go a long way to help demonstrating cost effectiveness, because they think about it in ways slightly different than we do. So, yes, ma'am.
I noticed you mentioned, should I wait for, oh, sorry.
Yeah, there.
You mentioned cultural competence, and I think along this conversation of social work carving out much more of a larger remit in terms of what social workers can do in healthcare, makes me think of the concept of structural competence as well as cultural competence. And I think that is, it was originally developed more for medical school training, but I think it is a concept that we should embrace in the profession as sort of connoting these larger, more upstream issues that we can bring into practice in healthcare in ways that other professions can't or don't.
So by structural competency, do you mean work with other professions or within the structure of
It's
the health
it's
system?
part of sort of training the health professions to be.
Yes.
It's a lot of this has been mentioned today, but it's bringing it in much more in terms of actually bringing it down to a level of training. Physicians, social workers, I think, can be part of that, not only training, but in
Definitely.
practice, bringing
Definitely.
in these more upstream, this sort of more holistic view of social determinants
Yeah, I can
under that heading.
I can. Yeah.
Yes, Jonathan Metzel and Helena Hansen, who's at NYU. But I think it's an article we should, it's something I think we should think about
Yeah,
in social
I mean,
work.
can you imagine a situation where physicians at the, in the medical school stage are getting trained side by side with social work students at the master's level, so that a lot of these issues about what's your area and what's my area get ironed out way ahead of time, so that the physicians likewise are coming out and saying, where's my social worker? I know exactly what this person can do, and it's not the kind of public sort of fuzzy perception that, well, don't they just do child welfare work, or don't they just work with the homeless, or something like that?
Yeah, I mean, my interest is in housing instability and how that feeds into how it permeates the healthcare system. But I think this is a way one direction we could go.
Sure. Thank you.
Hi. So I go back to the comment I made earlier. I think we are at a critical time where we together, and now I'm saying it's in my split personality of being social work and nursing, but that we can together, social work and nursing, as well as other professions, but particularly social work and nursing, turn the healthcare system on its head. So the reason I say this is, as you were talking, I went and I was not like checking my email. I had seen this
Thank you.
before, and while you were talking, I went back. I said, I got to go back to this email. It was an email I got just today that the American Academy of Nursing has funding through the Macy Foundation to look at nurses in primary care, because the nursing profession sort of has a crisis in primary care right now, too. And people who are called nurses are sometimes the medical assistants, and nurses are not used to their full capacity. And I really think that nurses and social workers together could look at primary care in an innovative way, and it doesn't have to be dominated by the physicians. And again, okay, I hesitate to say this, but some of my best friends are physicians. But I think we all know what we're talking about. That of course we like physicians, but the healthcare system has been dominated by physicians, and maybe there's something that we can do that's different. I don't know. I just think that we're at a time. Oh. Well, maybe we could. Really? Oh. Wow. No. And by the way, Diana Mason says hello to you. Yeah. Yeah, that's what that's exactly what I'm saying. And I really do, I really believe we could do something. So I'm excited about it.
Good.
So I just wanted to say thank you for imagining the possibility of social workers and physicians and other colleagues training together, because we have a very robust program where we're doing that. I know there are some other colleagues who do as well, and we'll have a great panel after the break. But indeed, when we are co-training social workers, physicians, nurses, and pharmacists together, while they're still in their training program, before they don't know how to speak to each other, while they're still forming their professional identities, one of the biggest outcomes that we have is that the other professions say, oh, that's what a social worker does.
There you go.
And even when I was just training smaller groups, now we have a very robust 260 learners at a time. I think I'm going to teach this class one more time. Every time somebody says that, if I have to do it, some small increment at a time. But the other big outcome, and this was mentioned before lunch, that is equally important is the social work students come out and say, one of the things that I learned is that I have to speak up and I have to voice what my role is. So I feel like by grabbing them while they're still in their educational program and training them together, we are starting to hit at some of these goals. And now we have to get the healthcare system ready to receive them when they get out there. And then they go out into healthcare, and then they come back and they say, but that's not what it's like when we get out there. And we said, we know. Now you have to go fix it. That's why
Yeah.
we trained you. So thank you for bringing that up.
Good, sure thing.
All right, shall we give thanks?
Yeah, thank you all.